Hey guys, welcome to Medifaction. Today, let's learn about ulcers. So basically, the diseases which we will be discussing today will be coming under the inflammatory bowel diseases. The term inflammatory bowel disease is commonly used to include two idiopathic bowel diseases having many similarities but distinct morphological appearance. They are ulcerative colitis and Crohn's disease. Ulcerative colitis. These are ulcero-inflammatory colitis affecting chiefly mucosa and submucosa of descending colon and rectum. Whereas in Crohn's disease, otherwise known as regional enteritis, is characterized by transmural non-caseating granulomatous inflammation affecting most commonly in segment of ileum or colon. The systemic involvement are polyarthritis, uveitis, ankylosing spondylitis, and skin lesions, and so on. So this is the picture of ulcerative colitis. Epidemiology. IBD, otherwise inflammatory bowel diseases. These are frequently present in the teens and early 20s. Ulcerative colitis is likely slightly more common in females. The hygiene hypothesis suggests that this increasing incidence is related to improved food storage conditions, decreased food contamination, and changes in gut microbiome composition. Apparently, this results in inadequate development of regulatory processes that limit mucosal immune responses. This in turn allows some mucosa-associated microbial organisms to trigger persistent and chronic inflammation in susceptible host. Etiological factors. These includes genetic factors, immunological factors, loss of epithelial barrier function, microbial factors, psychosomatic factors, even smoking and oral contraceptives comes under factors. Etiopathogenesis. Even though the exact cause is unknown, genetically speaking, there is 3 to 20 times this diseases occurs in first degree relatives. There is compelling evidence that genetic factors contribute to inflammatory bowel disorders. Risk of disease is increased when there is an affected family member. Several IBD-associated genes overlap with genes involved in responses to mycobacteria, including Mycobacterium tuberculosis and Mycobacterium leprae. One of genes most strongly associated with Crohn's disease is NOD2, otherwise known as nucleotide oligomerization binding domain 2, which encodes an intracellular protein that binds to bacterial peptidoglycans and activates signaling events including the NF-kappa B pathway. In addition to NOD2, two Crohn's disease related genes are ATG16L1, otherwise autophagy related 16-like, and IRGM, otherwise immunity related GTPase-M. So, this picture demonstrates the immune response contributing to Crohn's disease. When there is a bacterial exposure, the barrier defects which lead to the influx of bacterial components. And when they come in action with the dendritic cells, there will be activation of CD4 T cells, which leads to release of pro-inflammatory cytokines such as TNF, interferons, interleukin 13, and so on, which results in the immune action. Immunologic. Lack of immune responsiveness to dietary antigens and commensal flora. Activation of CD4 T cells secreting cytokines inhibitory to inflammation. Microbial factors. In this, some evidence, though not clear, infective etiology. In psychosocial factors, these are unduly sensitive and dependent on others. The presence of antibodies against the bacterial protein flagellin are most common in Crohn's disease patients who have disease-associated NOD2 variants, stricture formation, perforation, and small bowel involvement. In contrast, antiflagellin antibodies are uncommon in ulcerative colitis patients. Complication of IBD. Risk of colonic adenocarcinoma is increased in patients with long-standing IBD affecting the colon. Now let's learn detail about Crohn's disease. So, most commonly 15 to 25 centimeters of the terminal ileum is the place where Crohn's disease takes place, and they may also extend to cecum or even to ascending colon. Macroscopically, segmental and skip lesion and entire thickness of colonic wall is involved. The earliest lesion, the aphthous ulcer, may progress and the multiple lesions often coalesce into elongated serpentine ulcers oriented along the axis of the bowel. Deep fissures frequently develop between the mucosal folds and may extend deeply to become fistula tracts or sites of perforation. The intestinal wall is thickened and rubbery as a consequence of transmural edema, inflammation, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which contribute to stricture formation. In cases with extensive transmural disease, mesenteric fat frequently extends around the serosa, known as creeping fat. Crypt abscess will also be formed, which means within the crypt there will be dense neutrophil collection. Repeated cycles of crypt destruction and regeneration lead to distortion of mucosal architecture. The normally straight and parallel crypts take on bizarre branching shapes and unusual orientations to one another. Non-caseating granulomas is a hallmark of Crohn's disease. Cutaneous granulomas form nodules that are referred to as metastatic Crohn's disease, which is a misnomer since there is no cancer. So this is a gross picture, and this right here is the involved segment, and this part right here is the uninvolved or skipped area. And here you can appreciate the serpiginous ulcers, and this right here is the cobblestone-like mucosa. So in this histological picture, you can appreciate the deep fissure, and this right here is non-caseating granulomas along with giant cells and mature lymphocytes. Crohn's disease clinical features. Mostly intermittent attacks of relatively mild diarrhea, fever, and abdominal pain. Approximately in 20% people acutely with right lower quadrant pain, fever, and bloody diarrhea that may mimic acute appendicitis or bowel perforation. Periods of active disease are typically interrupted by asymptomatic periods that last for weeks to many months. Disease reactivation can be associated with a variety of external triggers such as physical or emotional stress, specific dietary items. Also, iron deficiency anemia and extensive small bowel disease may result in serum protein loss and hypoalbuminemia, generalized nutrient malabsorption or malabsorption of vitamin B12 and bile salt. Fibrosing strictures, particularly of the terminal ileum, are common and require surgical resection. Fistulae, perforation, and even peritoneal abscess. Extraintestinal manifestations of Crohn disease. There will be uveitis, migratory polyarthritis, sacroiliitis, ankylosing spondylitis. Right here, this is a healthy spine and this is a case of ankylosing spondylitis. There will be inflammation of joints. Likewise, erythema nodosum right here and clubbing of the fingertips, any of which may develop before intestinal disease is recognized. Also, pericholangitis and primary sclerosing cholangitis may persist, but it is very rare. Crohn's disease treatment. Immunosuppressive agents remain the mainstay of treatment, along with anti-TNF antibodies, since these are associated with inflammatory responses. This gross pictures shows that this right here is the small intestine stricture. This picture we can appreciate linear mucosal ulcers which impart a cobblestone appearance to the mucosa and thickened intestinal wall. This picture shows perforation and associated serositis. This right here is the creeping fat. In this histological pictures, we can appreciate here, which is nothing but the bizarre and branching crypts. In this picture, we can appreciate inflammation in full thickness of the wall, otherwise transmural inflammation. This picture shows inflammatory cells. So this is the microscopic pathology of Crohn disease. Next is ulcerative colitis. So this disease is limited to the colon and rectum. Extraintestinal manifestations of ulcerative colitis overlap with those of Crohn disease except primary sclerosis cholangitis, which over approximately in 2.5% to 7.5% of individuals with ulcerative colitis. This always involves the rectum. Disease of the entire colon is termed pancolitis. Mild mucosal inflammation of the distal ileum termed backwash ileitis with broad-based ulcers. Isolated islands of regenerating mucosa often bulge into the lumen to create pseudopolyps, and the tips of these polyps may fuse to create mucosal bridges. So this right here can be considered as a gross picture which shows the ulcerative colitis, continuous involvement of the rectum, sigmoid colon, and the descending colon are seen without any uninvolved skip areas. The ulcers are superficial and intervening inflammatory pseudopolyps. The lumen is narrow and hostile folds are lost, giving garden hose appearance. So this right here is the picture which shows the crypts abscess which I mentioned earlier, which is nothing but within the crypt there will be dense neutrophil collection. This is a clear, some more clear picture. Also there will be presence of mucosal atrophy and inflammation, and inflammatory mediators can damage the muscularis propria and disturb neuromuscular function, leading to colonic dilation and toxic megacolon, which carries a significant risk of perforation. Ulcerative colitis clinical features. It is nothing but a relapsing disorder characterized by attacks of bloody diarrhea with stringy mucoid material, lower abdominal pain, and cramps that are temporarily relieved by defecation. More than half of patients have clinically mild disease, although almost all experience at least one relapse during a 10-year period, and up to 30% require colectomy within the first 3 years after presentation because of uncontrollable symptoms. Ulcerative colitis treatment. Colectomy effectively cures intestinal disease in ulcerative colitis, but extraintestinal manifestations may persist. So this picture shows the gross pathology of ulcerative colitis. So this picture shows total colectomy with pancolitis showing active disease with red granular mucosa in the cecum right here. And on the right side, we can appreciate smooth atrophic mucosa distal to left side. Now in this picture, we can clearly distinguish between the active ulcerative colitis on the right side and normal mucosa on the left side. And this picture shows inflammatory polyps, whereas this picture shows mucosal bridges. So this is a table which will help you to differentiate between Crohn's disease and ulcerative colitis. Some of the important points are bowel region involved. In Crohn's disease, there will be ileum and colon, and in case of ulcerative colitis, there will be only colon region involving. And for the presence of stricture, in Crohn's disease, there will be presence of stricture, whereas in ulcerative colitis, these are rare. In the case of inflammation, it's transmural in Crohn's disease and it is only limited to mucosa in case of ulcerative colitis. And this is one of the important differentiation between these two, which is granulomas. These are present in Crohn's disease and it is not seen in ulcerative colitis. Likewise, toxic megacolon is not seen in Crohn's disease, whereas it is present in ulcerative colitis. Also, skip lesions are seen in Crohn's disease. You can see here the lesion is there, here the lesion is there, but this area is skipped. Likewise, as I told earlier, transmural inflammation, ulcerations and fissures are seen in Crohn's disease, whereas in ulcerative colitis there is continuous colonic involvement beginning from the rectum, and also presence of pseudopolyps are seen in ulcerative colitis. Hope you understood the video. Like, subscribe and press the bell button for more videos. Thank you. Thanks for watching.